And it's a good question. I think as we think about commercialization, we typically focus on two sides of the equation. One is channel access, or one is channel strategy, and the other is kind of access strategy. And I think the paper that you saw was very focused on channel. So how many pharmacies and how should that vary by type of drug? We didn't spend as much time in that paper really looking at access, which is typically where we would put a health equity focus. I think I went back and talked with the authors of the paper that I worked with on that, and I think as we think about it, from a health equity perspective around access, there's probably three big things to think about. One is clinical trials, and certainly I think most manufacturers pretty openly talk about this now, and the fact that clinical trials historically have been overrepresented by a Caucasian majority in terms of the participants, and they're very underrepresented in terms of people of color. And so rethinking how clinical trials are designed is important to establish better equity in the pipeline. I think the second thing is really understanding data. And so we know both within clinical trials, but also in broader access, if you don't understand the subpopulation and the effect that that could have, within different specific races or within specific populations that may not have the same access to healthcare, or may not have the same access to internet, or may not have other things that we typically refer to as the drivers of health, figuring out how to address those so that we don't end up with this theoretical model that provides access, but in reality doesn't actually accomplish that. And then I think the third thing I would say is really thinking about the ecosystem and kind of root causes at its core. So if we think about things like common biases that people have, we know there's a cognitive bias, which is sometimes referred to as belief in a just world, which says that people who work hard are likely to be successful, and it's kind of the whole bootstrap mentality. But I think we know that that's not true because of systemic racism and other issues. And I think you could take obesity as a perfect example. Now that we have obesity specialty drug out there, many doctors and others would look at an overweight patient and perhaps assume that, well, if they just ate better or took better care of themselves, this wouldn't be a problem. But we know the reality of obesity as a disease, and the need to be able to address that and talk with the individual very differently is important. So I think it really gets to this data issue of thinking about how does somebody plan and think about the drug, the plan design, the whole components of access to be able to say, what do we know are limitations? If we think about a limited network, which is fairly common today, does that disadvantage certain populations or certain people? For example, some work I was recently doing around low income subsidy, or the extra help population within Medicare. We did a bunch of primary research, and one patient was sharing with us that it takes her 3 buses and sometimes a few hours to get to the pharmacy. So if we start thinking about driving people to a particular site of care, which might be cheaper, but that's not on the bus route and harder to get to for a certain individual, we've made it almost impossible for them. We know that that's the same with infusion in some cases, where I might have to take time off work. And if I imagine myself in a hourly position where I don't have the luxury of unlimited paid time off and I can't easily get away from work, how do I go and get that infusion when the clinic might only be open during my working hours? So I think understanding how those components limit access and how they disproportionately affect underrepresented minorities is important. And I don't think we often spend the right amount of time looking at the data and doing the right kind of patient facing research to understand that versus focusing on the disease. Sure. So I think, there's lots of discussions right now around, how to create a more equitable future of health. And I think as Deloitte define it, we talk about the fair and just opportunity for everyone to fulfill their human potential, in healthcare. And so, that being both physical and mental health. And I think you've seen certainly this lift in focus around behavioral health over the past year and a half during the pandemic. I think to your point about data, part of it is being transparent. So, it's not just measuring the data and keeping it internal. It's holding yourself, to the higher standard of being able to publish some of that data and show what you're doing and how you're doing it. I think it's being able to, track and use that data to show specific results. So how do you really look at, ways that the data changes your behavior? So a couple months ago, there was a Medicare plan, and they presented at a conference, and it was the first plan I'd seen that presented their data around star metrics, which are quality metrics in Medicare, and showed the data by race. So they showed how adherence varied by therapeutic category, by race. They showed how pharmacy utilization varied. Specifically, they then drilled into the Latinx population and showed within that subpopulation how they thought differently about pharmacy, why they were underutilizing, for example, 90-day prescriptions, and different ways to really engage with that population around their healthcare. And so I think, being able to take that data and use that data, is important. I think we also have to just acknowledge the reality that, healthcare has become massively complex. And so, thinking about how we simplify healthcare when, I think most of the measures I've ever looked at over the years say less than 25% of people are really health literate in the US. So as we create a massively complex system that really allows people that are fully engaged with the system and trust the system, to be able to do something, I think we create, more systemic limitations for populations, because we know, poor individuals, people of color, LBGTQ plus populations, they all don't trust the system in the same way as others do. And so, how do we think about how to engage them and what the right way to use data and represent that data back to the market and to our own employees, honestly? Because I think, sometimes we see companies that do invest out in the community, but still haven't spent the time to get their own population fully aware, fully understanding, implicit biases that they might have, so that, they address those. We even have one client now where we're going through and revisiting their AI algorithms to understand and make sure there's no bias inherently built into the care algorithms that they use, because we know that there's been a few studies that have shown some bias built into the way that care is delivered, and even the research that led to best practices historically. I don't think consolidation in and of itself either helps or hurts health equity. I think a lot of it happens in how things get implemented. So if you think historically in specialty pharmacy, you might have a pharmacy that was focused on one drug, one disease, and they could really go and understand the patient, and in some cases the community that they were in. So we could think about HIV traditionally as a subpopulation where, the pharmacist and the pharmacy really understood the patient and how to engage them and how to think about perhaps access issues or, questions that they might have and how to engage them. Now, on the flip side, you could say at the large specialty pharmacies, you may have the ability to do that at scale. And so the question is making sure that as you take advantage of scale and the data that you get, that you think creatively around how to use those resources to look at, things like trust, to look at specific ethnic differences or ethnic needs within the population, to think about the drivers of health and how those could be addressed. Because now there was a study I was reading over the weekend that was looking at specifically at cancer and breast cancer, and the fact that Black women are 40% more likely to die from breast cancer compared to white women. And their whole focus was on developing and putting out there a solution around culturally competent navigators that could help Black women to manage their disease. And so I think they were partnering with one of the Olympians to do that. And so I think you see that, and that's the kind of thing sometimes at scale that can be done. And I think, taking advantage of that at both ends of the spectrum is important. Yeah, I think as we think about specialty pharmacy, these are typically our most complex, most expensive patients. They have multiple comorbid conditions. Getting in and thinking about, their challenges or the, drivers of health, whether it's transportation, whether it's, resourcing, whether it's literacy, whether it's financial. I mean, that's something that pharmacists, I would argue, have been doing for years. I think we're getting better around more data. We're getting better as we see some integration of medical information into the pharmacy. But I think there's still, fundamental challenges that need to be addressed, especially as we talked about briefly earlier around plan design. And so if we think about, something that says, oh, well, you can get access to coupons, you just have to go to the internet. Well, what if somebody doesn't have great internet access or isn't particularly literate in how to use the internet to find the coupons? What if, somebody can only call the call center between certain hours and they work during those hours, or they're caring for kids, or, in specialty pharmacy, often, the drugs are delivered to your house, but they want, a confirmation and a time window. Well, what if you're not home? What if you're not in a neighborhood where you can have a $5,000, $10,000 drug left on your porch, or you live in a, apartment building where, it's not secure to just leave that package outside? All those things become challenges. And I think we've under indexed on really analyzing a lot of the components that are there to save money. So we could think about, limited distribution networks. We could think about, formulary exclusions. We could think about prior authorization, utilization management. Do those things create challenges because they do require somebody to have time, to have access, to be able to ask the right questions? I think about when we would exclude a drug from the formulary, we'd often talk about the fact that there's a formulary override process. Well, I bet, 95% of people in healthcare don't know how to tap into the formulary override process, much less, somebody that's disenfranchised or doesn't trust the system. And I think this becomes more and more important as we look at all the things that are being done to try to control spend, whether it's reference-based pricing or others. As we think about limiting the network, we know, that in some cases, trying to look at the stat here, it talks about 55% of people who identify as Black, Hispanic, Asian, or Native American reported a negative healthcare experience where they lost trust in their provider, and 36% of them avoided care because of that, and 4 out of 5 said they would never return to that provider. So as we limit access to specific pharmacies or specific physicians, are we monitoring and really understanding the trust level and the satisfaction level at the subpopulation level to understand what if they didn't have a good, and they don't trust that pharmacy, that provider? What if they happen to be in a community that doesn't have a whole lot of hematologists and they, are specifically at risk for, that type of disease? What does that mean for them? And are we actually measuring our plans and our clinical decisions to make sure that we, aren't creating unnecessary barriers for people that are already systemically limited in, having an equitable access to be healthy?